All right. Good afternoon, everybody. Happy end of the semester for many of us. Happy holidays. I'm excited to announce today's presenter for today's presentation, introduce them, which is of great interest to many folks on this call and for those affiliates and people involved at InCHIP. So Dr. Meyer is a associate professor and associate professor of medicine and public health at Yale University and the director of the Infectious Disease Fellowship Training Program. Notably, she is an UConn alum, receiving her MD at the University of Connecticut School of Medicine. She's a practicing physician who's board certified in internal medicine, infectious diseases, and also addiction medicine. Her NIH-funded clinical research lab focuses on HIV prevention and treatment for women, addressing social and structural determinants of health. Her ongoing projects involve HIV prevention and treatment interventions for women involved in criminal legal systems, attending to reproductive health needs, intimate partner violence, and substance use and disorders and homelessness. Her clinical work and research is motivated by her experience working as an HIV care provider at the only women's hospital and jail, prison and jail in Connecticut. I just want to let you all know before we start, we'll all be muted during the presentation. And at the end of the presentation by Dr. Meyer, you can ask questions or you can type your questions into the chat. And in the event we run out of time to answer some of your questions, Dr. Meyer has graciously agreed to respond to your questions via email after the talk. And so without further ado, I'll pass it over to Dr. Meyer to present her talk.
Thank you so much, Ryan, and great to see you all. Thank you so much for inviting me to be here. I'm really thrilled and honored. I'm going to share my slides. Hearing
Yeah, we
They
see
look
it.
great. So, okay, guys. Okay, sounds good. Thank you so much. Okay, great. Well, I am really excited to be here today to talk to you about rising above barriers, HIV prevention and treatment for women with substance use through an equity lens. Um, and here are my disclosures. I have no conflicts to disclose. So just kind of to lay the background here for my talk today, I just want to acknowledge we just celebrated World AIDS Day, December 1st. And this year's UNAIDS World AIDS Day theme is about overcoming disruption, transforming the AIDS response. And in their report, the UNAIDS really focuses on the impact of the HIV funding cuts globally and the vulnerability of the HIV response in terms of several key groups of people, and that is people who experience gender based violence, those with substance use, those who engage in sex work or transactional sex, and the sort of downstream effects on women's sexual and reproductive health. And it's really people experiencing these kinds of things that really inform my work, and so that's what I'm going to talk to you about today. And this is also just to acknowledge the ways in which it aligns with the InCHIP theme this year, which is about health equity and social justice approaches to the prevention and treatment of HIV and other infectious diseases. So, my goals today are to talk to you about the gaps in HIV prevention and treatment for women with substance use. And I do want to acknowledge that some of my projects do enroll both cis and trans women, although I'll primarily be focusing on cis women today, and I'll just use the word women for shorthand. Um, we'll talk about strategies to close HIV prevention and treatment gaps using a health equity lens, and really to share kind of what we have going on, some ongoing implementation of these novel strategies to enhance HIV prevention and treatment for women. So, our team's work is really situated in this space. This is my awesome lab. We use clinical and community research to inform, develop, and test HIV prevention and treatment interventions that are specific to women, and to do so by addressing key social and structural determinants of health. Um, While large scale clinical trials establish evidence base for interventions, they often enroll sort of ideal patients, and they sometimes exclude women and they sometimes exclude people with substance use. And so we are working out in the community with real world implementations, real world challenges, real world patients, and all of the messiness that comes with it, so that we can tailor interventions to the people who need them most, and really try to make it work for them. So we're based out of 270 Congress Ave in New Haven, which means we're co-located with the New Haven Syringe Services Program and the Community Healthcare Van, a mobile medical clinic. It's been in existence since 1991.
A lot of options.
And we operate along within the framework of a status neutral HIV prevention and care pathway, which, won't come as any surprise to any of you here. Okay. And it also won't come as any surprise to this audience that there are over 30,000 new cases of HIV diagnosed in this country every year. We've already failed 2025 benchmarks by quite a bit. We have a long way to go to get to the ending the HIV epidemic goal of only 3,000 new HIV infections by 2030. But we do see some progress. There's a silver lining. We do see some progress over the past few years in terms of declining numbers of estimated incident infections. And while people with female sex assigned at birth comprise about 20% of these incident HIV infections, their estimated HIV incidence has been relatively flat over time. So the 12% decline in incidence is mostly among men. Women are just not benefiting from current HIV prevention approaches in the same way that men are. And that's not because of anything biological. It's just that we have a reach problem. Okay, perhaps an important contributor to that dent in the HIV epidemic. We've seen a steady rise in the number of new initiations of PrEP over the past decade since it was first introduced and FDA approved. And this is all PrEP products, both oral and injectable. And there's incredible power and potential of PrEP for women. We know that it is highly effective at preventing HIV in cisgender women, particularly when adherence is supported. There are multiple formulation options, which is supportive of patient choice. So that includes, a daily oral pill. Currently, only TDF, FTC, or Truvada is FDA approved for cis women. We also have long-acting injectables like cabotegravir. Now we have once or twice a year lenacapavir, and then not FDA approved, but recommended vaginal rings. Right, lots of options. Unlike lots of other HIV prevention modalities, PrEP is fully user controlled. So, no partner participation required. You do not need to negotiate PrEP with your partner like you would need to negotiate condoms. PrEP use is discreet. You don't need to disclose to a partner that you're on it. And it is both event and risk behavior type independent. And that becomes really important to women because they often experience overlapping risks. Not everyone's risk is just related to having sex with men or just related to substance use, but often people overlap. And it's really that women with substance use are a key population for HIV prevention. And that's because they are a population at substantive risk for HIV. So sometimes that's related to injecting and other substance use, which we know is associated with behavioral disinhibition. But it's also for women that they often have high risk partners or are within sex and overlapping sex and drug use networks, right? So you're having sex and using drugs with the same people. Um, Women with substance use may experience exchange sex, where they're trading sex for drugs, money, basic housing, food, right? Or even engaging in survival sex. They may have reduced social capital or agency to negotiate condoms with their male partners, which makes something like PrEP even more important. And women with substance use disproportionately experience intimate partner violence, which sort of reduces their capacity to negotiate things like condoms. So, for all these reasons, they experience increased risk of bacterial sexually transmitted infections like chlamydia, gonorrhea, and syphilis, all of which are associated with increased HIV risk. And then we know that stigma and shame deters women from accessing care. And when I say care here, it could be HIV testing, could be engagement in HIV care, it could be engagement in PrEP. And that's especially true for women with substance use in pregnancy, and particularly as, increasingly there are policies designed to criminalize substance use in pregnancy. So, despite what we've seen as incredible promise and progress, we know that women have just been underserved by PrEP, that only 15% of all women with indications for PrEP had received it by 2022. So, this is about implementation and adoption gaps. And as a result, there are these sex and gender based disparities. And we know that that only compounds other important disparities by age, race, ethnicity, and geography, right? So often the people who need PrEP the most at the time they need it the most just aren't getting it. Women also have reduced uptake of newer PrEP modalities like long acting injectables. And this is going to become really important to consider as we roll out lenacapavir for PrEP. Just the exciting potential of once or twice a year dosing that was extraordinarily effective in cis women in clinical trials. This is work that was done by Liza Koshy, who is one of my former MPH students, where she looked at disparities to access in long acting injectable antiretrovirals, both for prevention and treatment. But I'll focus on the prevention part here first. So, we did a retrospective cohort study of all patients who were prescribed antiretrovirals for PrEP between 2021 and 2023 within the Yale Center for Infectious Diseases. And we there were 238 people on PrEP, of whom 63 were on long-acting injectables and 193 on oral. And when we compare the groups, we found that the correlates, in terms of correlates of being on long-acting injectable PrEP, this time it was only cabotegravir, we found that women had an 89% lower odds of being on long-acting injectable compared to men. So it's unclear whether this, it's just an observation. It's unclear whether this is due to provider biases, patient awareness or preference, or something else, but it's probably a combination. And I'll tell you a little bit later about a study that we're currently doing to try to promote gender equity in terms of access to long acting injectable antiretrovirals for treatment. So, where are we in terms of sex and gender differences along the status neutral continuum? Here we see the ending the HIV epidemic indicators by sex or gender. So here's female. Believe this is sex assigned at birth. So female on the top here and male on the bottom. So we can see that, as I said, women comprise about 20% of all incident infections. They also comprise about 20% of all prevalent infections. And when women are diagnosed, they're more often aware of their status as compared to men. However, they're slightly less likely to be linked to care. Of those linked to care, slightly less likely to be virally suppressed on the national level, and certainly less likely to receive PrEP for prevention on the other side of the continuum. Okay, so why? Why are women falling through the gaps? When we think about prevention, one way to think about barriers to PrEP access is using this socio-ecological framework where PrEP, this key element of ending the HIV epidemic, we know it's effective, but it's underscaled because of patient factors like low risk perception and structural factors like stigma in healthcare settings, clinical demands on patients, right? Lots and lots of barriers that are only compounded for women. And this is, even in Connecticut, right, where we have Medicaid expansion, where we have Connecticut AIDS Drug Assistance Program. We have tons of resources. Even here, there are all these barriers at play in terms of women accessing PrEP. In qualitative work that we've done, and quantitative work, frankly, over the past nearly 2 decades, here's what women sort of tell us about PrEP. They tell us that they engage in behaviors that clearly confer HIV risk, but they don't recognize it as risky. And because of that, they are underestimating their personal risk for HIV. In fact, even the word risk doesn't really resonate with a lot of women. Many aren't aware of PrEP, or they don't think PrEP is about them. And that is only reinforced through messaging. There's more ads now out that do show images of cis and trans women. However, as of today, the CDC material online about PrEP, the only picture of a woman we could find on there was a female physician who was prescribing PrEP. Everything else is sort of catered towards men who have sex with men. Women tell us that, yeah, PrEP sounds nice, but they have a lot going on in their lives, many competing priorities. And frankly, at the times in their lives when they're engaging in the highest risk, when they could most benefit from PrEP, they have the most competing priorities. So there's the challenge there. But we do know that they can change their minds about PrEP when provided more information, and I'll tell you more about that in a moment. Okay, so how can we close these adoption gaps in HIV prevention and treatment for women? Going to try to present here sort of four main approaches to closing gaps, and I'll talk about some of our ongoing work that uses each of these approaches, but acknowledge that like these gaps, these buckets are somewhat superficial, artificial, and that there's overlaps between them. And clearly, on a broader scale, we need lots of different approaches, and so we'll need a combination. So, in our ongoing projects, we've really tried to methodically construct different implementation strategies along the prevention and care continuum. We want to understand where the barriers are for women specifically and address each one with tailored solutions. So these are just some of the projects that we've done, thinking about we start with an HIV test. We usually do it as part of even screening to enrollment. If someone's positive, then we're looking at how to kind of keep them engaged in care and looking at tailoring towards viral suppression. If someone tests negative, we have lots of ongoing work, some of which I'll tell you about, that really looks at how to keep them engaged, get them engaged in PrEP and keep them on PrEP. Okay. So, when we look at that continuum, the very first step in HIV prevention and treatment continua is awareness. And we know that when women are more aware of their options for HIV prevention and treatment, they're better equipped to make choices. And so the first, bucket of approaches here is about empowering women to be informed consumers. And this is what I'm not a health economist, but this is about sort of demand side interventions that it can potentially address stigma, shame, and helps women be able to overcome potential provider biases. And I say that as a clinician myself, probably with my own built-in biases. Okay. So, we use decision aids to empower women to make fully informed choices about their options for HIV prevention. So, what are decision aids? These are patient-centered tools that can help people make informed decisions about their health. There are individual level patient decision aids. There are shared decision aid type tools that sort of facilitate conversations between patients, clinicians, or other people. Decision aids in general can take lots of different formats and cover lots of different topics, right? There's hundreds of clinical trials related to decision aids about things like, should I get a mammogram? Should I get a PSA screen? Like, should I start this particular medication? that help people weigh the pros and cons of doing something versus the pros and cons of not doing something. And there were, at the time we started this work, there were lots of decision aids out there. But the only ones really relevant to HIV were about, should I start treatment? And that was in the days before antiretroviral treatment. And like, should I get tested? So we developed a decision aid specific to PrEP and specific to women. And in our first studies, we tailored it to women with opioid use disorder who were in treatment. So the very early prototypes of our decision aid looked partly like this. This is a format called a decision grid. And so in each of the rows here, we have questions that other women with opioid use disorder who were in treatment had about PrEP. And we got this really from our formative work. So things like, how do I take it? Does it, interact with my other medications? Is it covered by insurance? What do I need to do? And when we first developed it, this was really only about daily oral PrEP. So you see here, it's like pros and cons of using PrEP versus the pros and cons of not using PrEP. Okay. And sort of like maintaining the status quo. And um, as time has gone on and we've evolved, we've had the decision aid has taken lots of different formats, but has become, more fancy, more technologically advanced, and more interactive as well. So people can choose what topics they want to learn more about and then tell us how important that topic was to helping them decide. And I'll tell you a little bit more, but we're continuing to adapt it to include more information about injectable PrEP now that that's an option. So, in these early studies on this PrEP decision aid, we worked with Glenn Elwin from Dartmouth. This is his picture up here. He's the former co-chair of the International Patient Decision Aid Standards, and we developed this PrEP decision aid specific to women with opioid use disorder in treatment. We enrolled 164 women and we tested it in a preference trial. So they could opt in to either receiving the decision aid or enhanced standard of care. And here in blue, you see the decision aid folks, in orange are the standard of care folks, enhanced standard of care, because at least we assessed their HIV risk and briefly counseled them on it. And we found that, people who opted into the decision aid were slightly more often PrEP eligible, slightly more often to perceive their risk, about equal to be interested in PrEP, at least tell us they were interested. Although those who got the decision aid expressed lots of interest in PrEP after they received the information. And then sort of what I think is most interesting is this part. So despite the fact that we only delivered the intervention once and then followed people for 12 months, we did not have any booster sessions. We did not have linkage to care that was active. We did not provide PrEP as part of the study. Still, people who got the decision aid were significantly more likely to have started PrEP by month 12. And although these numbers are low, when our base case is zero, I thought this was, we thought this was a success. So, we started out with support from the Doris Duke Foundation, developing this decision aid and tailoring it to women with opioid use disorder in treatment. It then worked with Tiara Willie, shown here, who's one of my colleagues and faculty at Hopkins, to adapt the decision aid further and design it to be delivered to women who are survivors of intimate partner violence through domestic violence service agencies in Connecticut. And then with an NIMH R34, we are just completing actually adapting it specifically to Black women who are IPV survivors in Baltimore, and again, delivering it through the domestic violence service agency. So kind of outside of a traditional clinical approach. The idea, again, empower women with the knowledge and awareness of PrEP, even before they talk about it with their providers, so that they can potentially, be the ones to advocate for themselves. And this is our study team at Springboard, which is a domestic violence service agency in Baltimore, doing training with all of the advocates there. And we wrote a little bit about our experience preliminarily. So invite you to take a look at that if you'd want to learn more. We also made the decision aid and sort of all of this formative work publicly available. So I'm including like the programming for REDCap. So there's a link here. Happy to share it with people who are interested. If because I think there's a lot of different spaces that this could move into. Okay. Um, what about these sort of demand side interventions, but moving it over to the HIV treatment part of the care continuum? This is really about trying to address gender equity in terms of access to long-acting injectable antiretroviral therapy. So it's really about Cabenuva. And this is a project still in the works. We're conducting a study of a pharmacist-led intervention to support injectable HIV treatment for women with health-related social needs. And I'll tell you a little bit more about how we defined health-related social needs in a moment. But essentially, this is a single-arm pilot study of an enhanced collaborative drug treatment management model. So we recruit women with diagnosed HIV who are virally suppressed on oral therapy, and they also have health-related social needs. So they might be people who like wouldn't really consider for long-acting injectable treatment, concerns that they might be able to engage and adhere to it. Um, and we connect them with our pharmacists, our amazing pharmacists who provide an educational intervention. And then we look and see what happens and if they switched or not. And we wanted to really understand um, if they switched and why or why not. So this was part of a presentation that we gave at ID Week that just happened in October. But as of that date, we had enrolled 33 people with a mean age of nearly 60 who were predominantly Black and non-Hispanic. And this is very much reflective of our clinic population overall, and particularly our clinic population of women who have been long-term HIV survivors living with diagnosed HIV for at least 27 years. And with, again, they met kind of standard criteria for long-acting injectable treatment in that, per the package inserts. They were all virally suppressed, very high CD4 counts. They had lots of health related social needs. So, like I said, these are sort of like imperfect patients, right, who would not necessarily have qualified for a clinical trial. Um, Almost all had housing instability or poor living conditions, food insecurity, criminal legal system involvement, and between 15 and 21% had ongoing moderate to high risk substance use, alcohol misuse, and depression. And so here's what's happened to them so far. So we've assessed 78 people for eligibility. We excluded 45 mostly because they didn't have any health related social needs or they were not virally suppressed on their oral therapy. Again, this is just the package insert per Cabenuva. Um, and we enrolled these 33 I just told you about. All of them completed a pharmacist visit. So just to show everyone that despite all of these health related social needs, they really can engage and do engage. And the outcomes of those visits were that 4 so far have been interested in switching to long acting injectables and received their first injection. We had 12 people who learned all about long acting injectable treatment, said, that's not for me. I want to stick with my current regimen, which is also a completely acceptable response. 14 deferred, and we're following them along to see if they ultimately will decide to switch and why or why not. And 7 were found to be ineligible, mostly because they had rilpivirine resistance, but there were some who were ineligible because they had concurrent hepatitis B and so wanted to be on a regimen that covered both. Okay. So that's a little bit about our demand side interventions. Sort of a second way to fill the gap is about acknowledging women's lived experiences, either with living with HIV. I'll focus on that here, and sort of thinking about their challenges with HIV care engagement in particular. I'll tell you a little bit about our recently completed eye care study. This was part of an NIMH RO1 on which I was co PI with Tammy Sullivan, shown here. And this is our amazing research team, um, including Laura Callanan, who is our statistician and did all of the work I'm about to show you. But this is really the overall the parent project was asking about how intimate partner violence affects women's engagement in HIV care. And, I know that I'm focusing here more broadly on women with substance use. And many of the women in this study did have substance use as well, which I'll show you. But again, they were all survivors of intimate partner violence. So we enrolled in this study, we enrolled adult women with diagnosed HIV and lifetime experiences of intimate partner violence, and it could have been physical, psychological, or sexual, to participate in a micro longitudinal study. And this meant that we recruited women from HIV clinics throughout the state of Connecticut. And we also did some community based recruitment to ensure that we could recruit people who were technically out of care by Ryan White definitions. We did a big baseline survey, a baseline interview, and we followed up with them 6 months later. And then, kind of the heart of this project is that we did twice daily data collection for 32 days. This is the micro longitudinal part, using either interactive voice response or MyCap or Ethica. And then for this particular analysis, we conducted multi level models of antiretroviral non adherence at the day level and at the person level. So for this study, we screened 322 women, of whom 275 were eligible. And eligible in that they were adult women with diagnosed HIV, regardless of whether they were in or out of care, who had had lifetime experiences of intimate partner violence. We ultimately enrolled 162 women. And then, for the purposes of the analysis I'm about to tell you, we looked at the 147 of those who were on oral antiretrovirals taken either once or twice daily, and the subsetted out to the 129 who had daily data available, which means they had completed at least two of the microdata surveys. So incredible volumes of data. We ended up with a complete data set of 125 women with 2,439 days of data and an imputed data set of 129 with 3,286 days of data. So our sample overall, again, highly representative of people with HIV in Connecticut. Of our 129 women, again, mean age 55. This looks a lot like some of our other studies. I realize 20% Hispanic, and the majority were Black. And only a small proportion were currently employed. Um, Everyone was insured, really reflective of the Medicaid expansion state in Connecticut, and they had access to medications. In that, we have the Connecticut AIDS Drug Assistance Program, although not everyone was on medications at the time of study enrollment. They'd been living with diagnosed HIV a long time, and almost all were engaged in care by Ryan White definition, and almost all were virally suppressed. So this is a very well controlled long-term HIV population. And yet they had a lot going on in their lives. So they had very high prevalence of lifetime and current unhealthy substance use. About a quarter at enrollment met criteria for hazardous drinking by the audit. About three quarters had ever used cocaine, and of those, 61% had moderate to high risk use. And there was the use of opioids over the lifetime was fairly prevalent. And there was moderate to high risk use of illicit opioids by about 67% and prescription opioids by 62%. Although these categories, illicit and prescription, the lines are pretty blurred these days. So, but overall, somewhere in the 60s percent had moderate to high risk use. Um, Everyone in this study had had lifetime experiences of intimate partner violence, and about half at baseline were currently in a relationship. And we were somewhat surprised to find that of those, 82% had experienced intimate partner violence with those partners in the past 30 days. And I think my colleague Tammy Sullivan, who runs the Family Violence Research Center, was not surprised by this. But as someone who takes care of patients in HIV settings and in HIV clinics and sort of sits in front of people all the time, it doesn't always come up. And so I was surprised to find that this is what people were navigating on a day-to-day basis. And of the people who had been experiencing more recent intimate partner violence, most of it was psychological. Some was physical, with or without psychological, and about a quarter of the time it was sexual, with or without psychological, and with or without physical. So, what happens in people's day to day lives, right? We had 125 participants who contributed 2,439 days of data. And here you see the sort of daily events along the x axis, percent is on the y axis. In blue, I have percent of people, and gray is percent of days. So you can see that despite the fact that everyone's virally suppressed, almost everyone, um, 40% of people experience some missed doses of their HIV meds that occurred on a minority of days. Um, Relatively high ongoing substance use, most of which was alcohol. A smaller proportion were stimulants or opioids. And among people who were partnered, um, uh, over 70% had experienced any intimate partner violence as they were sort of recording this for us in their twice daily data collection. And that occurred on 40% of days. And we looked at not just whether or not, not just among the subset who were partnered, but we looked at overall people's daily maximum IPV distress. And that is sort of on this scale of the event did not happen. No IPV happened, either because you weren't partnered or because you were, but you didn't experience IPV. And then we looked at when the event happened, sort of how distressing this was. So we did multi-level modeling, and after controlling for age, there was no significant effect of substance use on ART non-adherence. And this was regardless of how substance use was operationalized. Um, we looked at lots of different interactions with daily maximum IPV distress, and again, it didn't was not a great predictor, a significant predictor anyway, of ART non-adherence. That's true of whether we looked at complete data, imputed data, day level, lagged models. There were some nuanced findings about heavy alcohol use and marijuana use, however, and hope to share that with you all as we go to kind of write up our findings. More to come. Okay. Sort of a third bucket to address the gaps are supply side interventions. And that is about delivering care in a way that makes sense for women's lives. So, this really gets to the idea of differentiated service delivery for key populations. In the latest iteration of the consolidated guidelines on HIV, viral hepatitis, STI prevention, diagnosis, treatment, and care, the World Health Organization focused on five key populations who sort of need tailored service delivery models. And that included people who inject drugs, gender diverse individuals, sex workers, and people in prisons and jails. It also included men who have sex with men, but obviously I'm not addressing that here. But the other groups really are all about include, women with substance use and experiencing some of the factors that we're talking about. Okay. So one way that we have tried to develop models for differentiated service delivery for HIV prevention tailored to women with substance use is by delivering integrated care and by doing it using telehealth and therefore lowering barriers to entry. So we have a currently ongoing a NIDA RO1 called Project Athena, and these are our awesome partners at University of Alabama, Birmingham, Karen Cropsey and Ellen Eaton, where we're looking to see about how we can use telehealth to deliver integrated PrEP with medications for opioid use disorder, and specifically for women in the criminal legal system. Enrollment's ongoing. Our goal is 250. And this is a randomized clinical trial. So everyone in both arms gets HIV testing, pregnancy testing, STI, Hep C screening, referrals to care as needed. Everyone gets a decision aid about PrEP. And those in the active arm receive telehealth for integrated PrEP and MOUD with our on site care provider versus enhanced standard of care, which are these referrals out, sort of like siloed care as usual. Usually, people would have to go one place to get their medications for opioid use disorder and another place to get their PrEP. And we're doing it across two very different settings, New Haven, Connecticut, and Birmingham, Alabama, and really looking at all of the implementation challenges that are very different with sites. So, to date, we've enrolled 149 women, all of whom have criminal legal system involvement and opioid use disorder. And actually, we had another couple enrollments yesterday, so there's more. And we've just to tell you anecdotally, we've seen lots of challenges, even with telehealth, even with integrated care, in terms of getting people to engage in a way that works for them. We have some people who've started PrEP as part of the study, which is great. It's a lot harder to get them to stay on it, especially without incentives. And so, that remains an area to be tailored further. Um, and we've done lots of focus groups using nominal group technique to understand from both stakeholders and participants at both sites what gets in the way of starting PrEP. And time again, we end up bumping up against competing priorities. And so this is all about developing care in a way that works for women, and so they don't have to feel like they have to choose between starting PrEP or doing something else. Um, Another way that we've been working on integrated care delivery is, and this is again specific to PrEP, is really about thinking about a no wrong door approach to PrEP. Right? You shouldn't have to. I mean, I like seeing people in my HIV clinic, but you shouldn't have to go to an HIV clinic to get PrEP. And we already know that women might not want to go there. Right? Might not want to be seen in the waiting room there, might not identify themselves as someone who needs to go there, right? So, in Project Carmenta, we're integrating PrEP capacity building and delivery and patient education and patient decision support into family planning clinics. Um, we've done lots of formative work planning for a clinical trial, working within the New Haven Primary Care Consortium. So we're involved in family planning clinics at Fairhaven, at Cornell Scott Hill Health Women's Center, and at Yale Complex Family Planning, which delivers slightly different models of family planning, and worked with stakeholders and participants, so lots of different perspectives, and our community advisory board to sort of build out this PrEP decision aid that I already told you about, and try to implement it in family planning settings. And then another component of that is really about capacity building for PrEP and family planning clinics. And I really want to tell you more about the formative work, but I think I'm going to skip through some of these quotes just so that I make sure I have time for questions at the end. Um, So the sort of last bucket about filling the gaps is honestly the hardest work, and that is about advocating for system level change. So, structural interventions require dismantling, rebuilding the very issues, the very factors that drive women to experience HIV risk, or to acquire HIV, or to be sort of unable in some ways to engage in HIV prevention and care. And so that looks like housing interventions, which we've done some work on housing interventions around integrated delivery, um, stigma reducing interventions, um, certainly decarceration. I haven't touched on that as much, but if we think about sort of decriminalization of substance use on women, that in decarceration is part of that. That certainly helps lower barriers to access to prevention and care, makes people want to engage. So, I'll just close with some take home messages. Hopefully, I've impressed upon you that there are significant gaps for women that remain along the HIV prevention and treatment continuum. We have the tools, but not the reach. Um, and I've talked about sort of four approaches to closing gaps that we are in the process of working our way through. So one is demand side interventions that really empower women to be informed consumers of care. The next is really trying to understand people's daily lived experiences to better design tailored interventions. The third is delivering care in a way that makes sense for women's lives, sort of acknowledging what we learned in number two. And that is by integrated care approaches, delivering PrEP, particularly no matter where people go. That's sort of a no wrong door idea, and really integrating PrEP into clinical practice that is already happening where people are already getting care. And then finally, the hard work, really advocating for systems level change and structural change, which takes a lot longer. This work would really not exist, and I would not want to do it without this amazing circle of lab mentors, mentees, collaborators. And I just want to close by acknowledging the incredibly tenuous funding environment in which we now live and work, and many of you do as well. And that's really a place where the work that we do, that's focused on women's health, gender, health disparities, HIV prevention, substance use, carceral systems, once was a priority, but now is under attack. And I do want to acknowledge that this work really would not exist without the NIH support. And so, hopeful for the road ahead, but there are certainly challenges. And to thank all of you, and happy to take questions.
Please join me in thanking Dr. Meyer for the wonderful talk. It was really great. We have
Thank
about
you.
12 minutes for some questions. And so, pretty flexible. If anyone wants to just unmute and talk, raise their hand, or throw it into the chat, I can help to make sure everyone's questions are answered. PJ, saw you first.
Hello, can you guys hear me?
Yeah.
Yes.
Okay. Oh, okay. Hi everyone. I really enjoyed this presentation, Dr. Mayer. I think it was very informative. I'm actually curious, in terms of we talked a lot about PrEP. Um, I'm actually curious, have you also done any work with post-exposure or PEP? I think I've been kind of getting like reading about it more recently, and I think maybe it might be like more useful for maybe survivors of one-time incidents or isolated incidents, or if you like have any kind of recommendations about like where the research is going with having post-exposure also available for access to women.
Yeah, thanks so much. And I look forward to talking to you more, PJ. I know I appreciate you having reached out to me by email.
Thank
Uh,
you. Me too.
yeah. So, in terms of PEP, yeah, I think honestly, the field is moving. away in some ways for PEP, from PEP, particularly for non-occupational post-exposure, because it's just we've sort of come to understand more and more that people experiencing risk often experience repeated risk and ongoing risk. So certainly there are people who experience a one-time sexual assault, and then PEP is totally appropriate for them. But for many of the people that we work with, their risk is recurrent, and so they need sort of longer term tools to protect themselves. The places in which PEP has really come up for us, so we've never done like a dedicated PEP intervention. That's just sort of not the space I work in, but the place that's come up for us is when we are collaborating with domestic violence service agencies. A lot of them are aware of PEP because they've seen it be used post sexual assault, but they don't really know anything about PrEP. So I have to do a lot of explaining of sort of like what is PEP versus PrEP and how are the two different.
Okay, so that makes sense. So kind of like becoming even more proactive and going from post-exposure to pre-exposure, because it's a lot of these times it's like the same populations, the same people who are most at risk. So,
Yeah. I think the places where PEP is kind of has is often confined to like emergency departments, where people are coming in for evaluation post assault. But in terms of the, community building, it's really all about PrEP going forward. Especially if we have, once a year injectable lenacapavir, that's a game changer.
yeah, I was also going to ask you, how do you feel about like Apertuda as well for injectable PrEP?
Yeah, more options, the better. There's some challenges to
Yeah.
Apertude. I mean, it's wonderful, but the challenges are really about that it is in intramuscular injection that can only be given in a clinical setting, and so people have to come back every 2 months. Hopefully, the dosing interval will extend as we get more data. But so for people who already have challenges getting to clinic, having them go every 2 months kind of puts a increased onus on them.
Thank you so much. I really appreciate it.
Thanks.
Thanks, PJ. Any other questions? We'd love to hear them. Jesse, can you hear us,
Jesse, are you
Jesse?
muted?
Me a little while,
Go
Thanks.
ahead.
slightly then. So thanks, Dr. Meyer. This was a really great talk. And I'm sorry, and I can't figure out the video thing right now. I'm still this computer.
Okay.
Sorry. Um, I love that you're talking. And I'm sorry, I missed the first few minutes. So if you were talking about, if you were framing this within the context of like a syndemic approach, I'm sorry I missed that. But I'm really excited that you, even if you weren't using the terminology, that you are looking at your work this way. It's very exciting. I was curious about the work that you've done with the domestic violence agencies. And kind of giving them, and I love the idea that you're guys talking about the task shifting, but I'm wondering if you've also kind of done some task shifting around or looked at the role in HIV clinics and public health, local public health departments to take on some of the violence prevention components within the context of
Mm.
their work around substance abuse and HIV prevention, because I feel like they know that they can do those pieces. They get really anxious, I think, about trying to approach domestic violence and sexual violence. However, we know they are so inextricably linked to these other health problems. So I'm curious if you guys have started exploring from kind of that side of it as well.
Yes, thank you so much. Great questions. So, it's funny, I did not put my syndemics framework in here, although I was honored last week to participate in a CIRA World AIDS Day talk that honored Meryl Singer and was all about syndemics. So happy to share those slides if anyone wants to see that. But yeah, that was like all about syndemics, which was really a fun conversation. But yes, to your point, all directions are sort of needed to take care of women's needs. And I have not specifically done violence interventions. Actually, in the grant that I mentioned about intimate partner violence, that I did with Tammy Sullivan, our initial grant had a whole aim about a violence prevention intervention, and it was only funded with the promise that we would take out that aim, which is kind of
Oh,
interesting. Which is a shame. But so there's definitely more work to be done. And the idea I think that we had and is not yes, task shifting to health departments, certainly all the places where people get care, but even within our HIV clinics, we can see from this study, like half the people are partnered, and of those, 85% are experiencing ongoing violence, right? And yet, like as a provider, we're often not aware of it and don't necessarily know how to intervene. So, a referral to social work is like often insufficient. So yes, I think thank you. And there's lots of work to be done.
thanks.
All right, last call. Any burning questions?
Pauline already knows. She doesn't have to ask any questions.
This is true. It's good to see you all.
Good to see you.
All right. Well, I will then say thank you all so much for being here. Thank you so much, Dr. Meyer, for coming at the end of a semester and around the holidays to give us wonderful talk. And it was great to see you all. And I was privileged to host and moderate and excited about that. So have a good holiday, you all.
Thank you so much.
Thank you.
Take care, everyone.